Otherwise, you're welcome and open up your minds, ready to learn something new today. Thank you. A very good evening to you all once again. Um, Welcome to our monthly session of clinical pathological case series that happen every month at 7 p.m. to 8 p.m. East African time. So you're welcome to today's session. You can ask your colleagues, as we're about to start, ask your colleagues to log in, send a reminder to someone to log in, come, let's learn together. In today's session, I will introduce myself. I'm the moderator. I'm Dr. Anne Kaguna. I'm an emergency physician currently supporting Makerere University. And we have a panel of experienced emergency care providers that will be with us to share the experience through the cases they've handled, and we shall learn from them. So to start with the pre-hospital team, we have Miss Wangechi Winfred, who is an EMT student at Masinde Muliro University of Science and Technology. You're welcome, Winfred, on this platform. And then secondly, we have Dr. Asimir Rebecca, a senior resident of emergency medicine at Makerere University, who will be our case presenter for the emergency department. And our expert for this session will be Dr. Opejo Pius, an emergency physician and associate lecturer with Mbara University of Science and Technology. So you're welcome to this session. Just a few house rules. When you log in, kindly mute your microphone. If you have something that you would love to mention or say, you can type in the chat or raise your hand up. You'll be given opportunity to share with us. And then in case we'll have sessions where we shall interact with the audience. If you have a concern, a question, please feel free to air them out so that we are able to learn together. Just a reminder, this is a case-based learning. We get cases that are undifferentiated, and then we learn together with the team that has seen these patients, and then we take home some messages. So you're welcome to this session, and it's 6 minutes past 7 p.m. We shall start. As we wait for more people to log in, we have a quorum of 28 people, but we shall start as wait for more people to log in the interest of time. So over to you, Winfred. Are you happy to start?
Hello, everyone. Thank you, Dr. Anna, for this. Okay, so we start. So my name is Wangeshi. Thank you very much, Dr. Anna, for this chance. So our presenting complaint, our mother calls in via emergency help. So she had a 15-year-old girl who was seemingly harder to arouse since early that morning prior to call. And she had lethargy for 1 day and was vomiting for 2 days. So from the audience, what additional information would you want to know? I give you 1 minute for that. I can see Halima Amani saying abdominal, any associated fevers, yes. So we'd like to know if there's any additional information you'd want to get from the presenting complaint from the mother of her 15-year-old girl presenting with lethargy and has been vomiting for 2 days. So I can see someone mentioning GCS score, yes. Any associated fevers, yes. I think that's it. That's very helpful. Thank you. So Rebecca, kindly.
So, good evening, everyone. So at this particular moment, you've got an emergency call from a mother telling you that her child is having lethargy, has been vomiting. She's now seemingly harder to arouse. So what Wangechi is trying to ask you on the phone, and this is a mother reporting to you, what more information would you want to get from the mother? She has told you she's trying to arouse her child, and she's seemingly harder to arouse. Wangechi, over to you.
Thank you, Rebecca. So in this case, we headed on to perform our primary survey, and we checked and this we have to do the Dr. ABC. So we checked, sorry, we confirmed the airway in which the patient's airway was threatened due to the vomiting. However, we laid the patient on a left lateral position. So we confirmed the breathing rate, and it was at 33 breaths per minute, and what was not labored. And on the SpO2 measurement, the patient had an SpO2 of 95% on room air, and the chest was symmetrical and moving with respirations. So we also checked the bilateral breath sounds in which they were clear. And on circulation, the blood pressure was around 128/70, and a heart rate of 105 beats per minute, with a capillary refill that was more than 3 seconds. So the patient also presented with cold extremities, and with this we confirmed the heart sounds in which both were clear and heard, both the S1 and the S2. So we also checked the disability of the patient, and which the patient was lethargic with a GCS score of I was 3, the verbal was 4, and the motor was 5, and the pupils were equal and reactive to light. We also exposed the patient, and in this case, a patient was cold and the skin was dry, but with no source of infection. So on the first bit, I had so the scene size up. Of course, our patient was the 15-year-old girl, so we only had one patient, and the scene was safe since we got the call from home, from the dispatch, but we found the patient at home, and the patient did not have any cervical injuries, but in the mechanism of injury, the patient, this was not more of a trauma case, but more of a medical case. So another thing, we also prepared ourselves with the PPEs, in which we checked, we made sure we donned gloves, and we also wore our goggles, and that was how we managed our scene size up and primary survey. And so in this case, I'd leave Dr. Pejo to give us what are his thoughts, and what preparation and approach could we have done to this patient?
Yeah, I think Winfred and the team, you guys have done a good job. I'm looking at this as a situation where we are approaching from the pre-hospital aspect of view. After activation, of course, I noticed that you responded immediately and you went out as per the dispatch call. And it's very important to always remember that don't assume the scene is safe simply because it is in the house or it's at home. It can be in the house, but also there could be other dangers. It could be maybe some kind of a viral outbreak that might be significant. So don't always forget that it's important to consider scene safety in a 360 degrees for yourself, the patient, and the environment. And then, yeah, I was seeing there are some questions that are coming up. You needed a lot more information. Of course, the most important thing first as an emergency person is what threatens the life of the patient. The airway, you saw there was vomiters, and then you did the rightful thing, put the patient in left lateral position, and then try to clear the secretions. And then, of course, there was no sign of traumatic injury as per the information that you got. But yes, if you're in doubt, always try to make sure that you protect the airway, the cervical spine, just in case you're in doubt, if you're not sure. And then, yeah, I think you did a very good thing. And then, of course, the other thing is the random blood sugar. At this point, you should be able to do that at the scene. I know she's a girl. We don't have big issues with myocardial issues with young children, a girl of 15 years, but still, it's important at this point if you could also maybe do a 12-lead ECG, at least the first initial 12-lead ECG, in case you pick up anything that's significant that might actually contribute towards your management. Yeah, that's what I can take for now. Maybe what does the audience think?
Thank you, Dr. Pius, for the highlight, and thank you, Winfred, for showing us how you manage this patient in the pre-hospital area. Maybe what I would ask Dr. Pius to highlight for us is, once this call has come in, how would you, as the doctor on call, maybe to just highlight for us how we would approach preparation for receiving this patient in the emergency department, having received the handover from the pre-hospital. Thank you.
Yeah, that's very important. Again, at the ED level, the ED we always receive any type of patient, the undifferentiated patients. But for this specific one, you'd want, of course, make sure that your equipment and your drugs and side lab, what we call bedside diagnostics or equipments are in place. So first and foremost, you make sure that you have a space, a bed where you're going to admit this patient on arrival. And then you have your team in place, maybe a nurse, and maybe a few residents or an attending yourself. At least a team of about 2 or 3 people must be available to receive this patient. Then, of course, your supplies. You need to have some IV fluids there. You need to have some of your drugs there, like maybe insulin. You may be dealing with a diabetic case. You may be dealing with a poisoning case. So you need to have a few of your antidotes, depending on where you are. And of course, generally speaking, start activating at that point, you'd want to inform outside, maybe just a kind of information to the outside the facilities like the ICU, for example, just in case the patient deteriorates quickly from your ED and you want to rush to the ICU. And then, of course, this is, again, 15 years. In some facilities, this is where you say you're managing it at ED level, but what next? Is it a pediatrician or an adult endocrinologist? There is a gray area there. Legally, this is a child. Medically, some hospitals will treat this as a young adult, and therefore will go to medical after your ED stabilization. But yes, your ultrasound and ABG machines must be functional, or if there's a side lab which is near you, should be able to collect your samples and be able to channel it for a quick diagnosis. Issues to do with the CT scan or radiology may be yes and no, depending on how soon the patient comes. Yeah, but that's very important. So that's as far as the preparation is concerned. Does that seem to be satisfactory to you, Anne?
Yes. Thank you, Dr. Pius. Thank you, Dr. Pius. So now the patient is in the ED. Dr. Rebecca, over to you. Thank you.
Thank you, Dr. Pius. Thank you, Dr. Anna. I hope I'm audible. So from the EMT, we received this patient and got an ISBA handover.
Rebecca, is it okay if you mute one of your devices, please? We have feedback. Thank you.
Can you hear me? Are you able to hear me?
Yes, that's fine.
So we received this patient from the EMT team. And as the ED team, we had to repeat a primary survey for the patient. And with every primary survey, you assess, you find a problem, you intervene immediately before you progress forward in the algorithm. So for this patient, when we examined the airway, it was patent. There were no foreign bodies or secretions, but we noted that the patient had an altered mental state, was responsive to verbal, was really hard to arouse. So we figured the airway must be at risk. So amongst the interventions that we did, we elevated the head of the bed, made sure to, if the child is to lie any position, make sure she's being nursed in a left lateral position. We cleaned the mouth of any secretions and any secretion of vomiters, and made sure, put a mental note to keep an eye on the airway. When it came to breathing, the child was tachypnic with a respiratory rate of 35. Notably, she had a small pattern of breathing. It was a deep sighing type of breathing rather. She was saturating well at between 95 to 98% on room air. Chest was symmetrical with respiration. Trachea was centrally located. She had bilateral equal breath sounds. The chest was clear with vesicular auscultatory sounds. So at this point, because she's tachypnic, we think maybe let's give her oxygen, but we made a decision not to because she was saturating well. Chest was clear, but of course she's tachypnic, so we decided to just monitor for worsening SATs, having a target between 94 to 98%. When we proceeded to circulation, we noted her blood pressure was 105 out of 50. Compared to the report that we got from the EMT, it seemed like there was a downward trend. The pulse rate was 144, which was increased compared to what the EMT had told us. And the pulse was thin and thready, a really thin volume pulse with a CRT of 3 seconds. She had cold palms. The palms were very cold to touch. Heart sounds 1 and 2 were normal. And notably, she did not have any distended neck veins or elevated GV, anything to suggest of an elevated JVP. So at this point, she came in with an IV cannula with normal saline running. So we decided to get a second IV access, started fluids, took off samples for baseline investigations. That's inclusive of CBC, LFTs, and RFTs, and also ordered for an ECG and echo to be done. So at this point, I'll invite someone to project the poll questions.
Rebecca, in order not to lose time, I think you'll be proceeding
Okay.
as we wait for the poll questions. Oh, okay, they've showed up. Okay.
All right. There should be a second question. There should be a second question. All right. I think because of time, I will go ahead.
Rebecca, we'll close the poll session now. You can proceed to the next session. We shall have the answers to the poll questions later on in the chat.
Okay. Thank you. All right.
Rebecca, in the interest of time, let's proceed to the next session.
So because this child was in shock, we decided to start with a bolus of 20 mils per kg. This child was about 42. Okay. The poll is running now, Dr. Anna, so I don't know whether I should continue.
It's okay, continue. The poll has been ended.
No, there's a second poll I'm seeing, but I'll proceed.
I think Rebecca, just proceed. Anna will manage the polls. Eh? Rebecca, are you there?
Yes, I am there. Can anybody hear me? So again, the child was in shock. Fluids at 20 mils per kg. The child was 42 kilograms. On disability, we noted that GCS had dropped to about 11 out of 15 as compared to what was in the ISBA report. Pupils were equal and reactive to light. The neck was soft. However, the RBS we did as soon as we received the patient was reading high. So we continued the IV bolus that we were giving over 30 minutes. And then the question was whether to give potassium or insulin. At this particular moment, we made a decision to continue to the IV fluids and first resuscitate the patient and get them out of the shock state. So we continued the IV fluid bolus that we were giving. On exposure, the patient was warm to touch with a slightly febrile 37.8. And we noted that shirt and face had vomitus with no signs of rash or skin lesions on the body. However, the skin and mucous membranes were dry and flaky and had a skin tag of about more than 2 seconds. So again, that intervention, what we did was to continue IV fluids, give IV paracetamol for the fever, and continue to monitor temperature. If the patient the temperature was to increase, would proceed to employing measures such as continue to expose the patient and tepid sponging. So here, 4 questions are supposed to come up, but I'll skip them for the interest of time. So we proceeded to do a secondary survey. Head and neck, significantly, the eyes, the patient had sunken eyes. There was no pallor, no jaundice, no palpable lymph nodes, but the eyes were sunken. Her abdomen, significantly, she had mild epigastric tenderness on palpation, had grossly normal findings on the musculoskeletal exam. Neuro exam, she was conscious but lethargic, the GCS of about 12 out of 15. Neck was soft, pupils were equal and reactive to light. Carnix was negative, she did not have any cranial nerve defects, and also she had normal power and tone in all her upper limbs. And the skin tag was more than 2 seconds. She did not have any rash. She had normal hair distribution. No significant skin deformity. So I'd like to throw back the question to Dr. Pedro. At this particular moment, what are your thoughts? What are you thinking right now could be the differentials, and how can you comment on the approach and interventions made at this point?
Yeah, I think so far so good. We are progressing so well. And maybe one thing, as we concentrate on the patient, let's not forget the mother. I don't know where the mother is, whether she remained home or she came with us to the ED. But yes, it looks like far-fetched. Someone should be attending to the mother, maybe trying to cancel her away out of the ED. But yes, back to the patient. We have seen a number of things that bring us kind of concern. You saw a temperature there that I think 37.8 or 38 something. A fever. You've done so good to give something for fever, but it gives us to think that could be an infectious process going on. Maybe it's something, maybe malaria, or maybe some kind of febrile infections again. But generally speaking, I think you've been systematic enough. You have addressed the most important concerns. And now, it's time to focus on what could be, besides the the elevated sugar, which we have tried to correct, what could be the other pointers? What could be the other differentials? Like we said, it could be malaria. It could be a urinary tract infection. Have we done the urinalysis on this patient? We took blood for other CBC, RFT, LFTs. I had that. But we should also do a urinalysis, and specifically, let's roll out. This girl is 15 years. She's within the age. She could have started her menarche. She's within the age which could be pregnant, and could be dealing with maybe some ectopic or some pregnancy-related issues. But yes, even UTI, urinary tract infections, could be a differential. And then what else? What else did you say? Yes. Besides, I think we mentioned about blood gas analysis earlier, because we need to know, is there an anion gap, or of course this must be a metabolic process, but is there anion gap or non-anion gap process going on? And that can only be informative if we did the blood gas analysis. Any other issues that I've not mentioned? But I think that is it. Rebecca?
Thank you,
And
Dr.
Dr. Anna, what
Pius.
do you
Thank you,
think?
Dr. Pius.
Mhm.
Thank you, Dr. Pius, for the input. In the interest of time, would love to let Rebecca continue from here. However, kindly use the next 2 minutes to run over the sample and your head-to-toe exam if you must, giving us the significant findings. Thank you.
So so for this patient, significantly in their history, the mother came with the patient in the ambulance, and also history that we managed to get from the EMT via their sample history. So I'll just be reporting on the significant findings. So this is a child who, as reported, had history of lethargy and vomiting for 2 days. Child had the vomiting was associated with loss of appetite and mild abdominal pain that was non-specific and generalized according to the mother. She also noted that the color of the vomiters was yellowish to white. It was either before or after food, wasn't really specific if it was associated with nausea, according to the mother. And the child had normal bowel movements. However, she noted that prior to this illness, the child had been going to the toilet a little bit more than often and had been also complaining of increasing thirst. She'd been drinking a lot more water than usual. And the child had been, she noted the child has lost a bit of weight over the past couple of months. However, she still has she had a normal appetite, according to the mother, prior to this illness. She also noted that when the child started to develop these symptoms, vomiting, fevers, lethargy, general body weakness, the mother decided to go to the pharmacy and get over-the-counter medication to manage malaria. So she got Coartem and Ampiclox, but the child had not been improving until that very morning, when she became seemingly harder to arouse, and she decided to call for help. A mother also noted that the child doesn't have any chronic illnesses and is not on any chronic medication. She could not comment on the last normal menstrual period of the child. Neither could we get that information from the child because the mental status was altered. But she did note that the child started her period when she was about 11 years, and she had been having it regularly every month. The mother is diabetic, and so is her mother, her grandmother to the child, and the mother is currently taking metformin. That's what I could surmise from significant findings in history. Otherwise, other history findings were as expected or normal. So we proceeded. So our differential list included the child was in hypovolemic shock. Second, severe dehydration from the evidence of fluid loss, that is vomiting, urinal increased micturition habits, decreased intake, the fact that she had also clinical signs of shock. That's inclusive of
Rebecca, you've muted yourself. Kindly unmute.
Altered mental status, dry mucous membranes, sunken eyes, and delayed skin pitch. We also, at this point, made an impression of diabetic ketoacidosis in light of the child having hyperglycemia, urinary ketones. Acidosis, at this point, we could not confirm it because we cannot do ABGs in our setting here. But the fact that the child had acousmal breathing in addition to the other signs and symptoms they had, we had a high index of suspicion for it. And also the child having polyuria and polydipsia in their history and a positive family history of diabetes made that impression more likely. We also thought of sepsis in light of the fever, tachypnea, tachycardia, and altered mental status, gastroenteritis, in light of the abdominal pain associated with the fever and vomiting, malaria, the fact that it's endemic, she had a fever and had non-specific signs like vomiting, which was ruled out by a blood smear test that was negative. Urinary tract infections, which we shall see the urinalysis results. We also thought about pancreatitis, electrolyte imbalances. She has an altered mental status. And if we're thinking of DM, we think that maybe a high or low potassium or sodium could be an issue here. Pregnancy is also part of our differentials. She's of a child of reproductive age, so you can't rule that out, though we could not ascertain when she last had a normal menstrual period. Also toxicology. She's a 15-year-old adolescent. Could she have ingested a DDT or maybe an interaction between alcohol? Maybe she's abusing certain drugs that could cause you such a presentation. Yes. So yeah, so those were our differentials at this point, unless anyone else has other differentials to comment to this. We did an ECG for her and it was normal, just showing a sinus tachycardia, but otherwise we did not see any U waves or any flattened T waves or prolonged QT interval or a sine wave or peaked T waves to suggest hypo or hyperkalemia, respectively. So for our when the labs that we got, she had a normal sodium of 132, potassium was 3.2. Notably, during our initial resuscitation, we started a potassium of 20 millimoles in the IV fluids that we were running. So when this potassium came back at 3.2, we thought maybe we made a good decision to start that. Creatinine was 1.3, phosphorus was within normal range, 0.97. HbA1c was elevated at 7.5%. As I said, we could not do ABGs where I would be expecting to look at the pH, is it less than 7.3 as would expect in DKA, or look at the bicarbonate, which we expect to be less than 15 millimoles in such a patient. Urinalysis, significantly, she had ketonuria of 3 classes and a glucose of 28 millimoles. Leukocytes were trace, nitrites were negative, and she had a proteinuria of 2 classes, which in our low resource setting was enough to confirm a DKA diagnosis. If we had ABGs just looking at the bicarbonate, the pH, the hyperglycemia, it would have confirmed that diagnosis. So CBC, she had a WBC count of 8.27, neutrophils were within normal range, HB was 11.8. The BS was negative, HIV was negative. Unfortunately, we didn't get to doing an HCG for this child. So our goals of management, our major priorities were to correct the shock, correct the dehydration, and correct the acidosis. So this child was managed in the acute care unit under the pediatric ward, or under pediatric ward. So as I said, this child was in shock. We decided to first manage the shock. So we gave a bolus of 20 mils per kg. And remember, you're doing your primary survey, you have to come back and reassess. So when we gave her 20 mils per kg bolus, 30 minutes later, we came back and the patient was still having clinical signs and symptoms of shock. So we gave her second bolus at 10 mils per kg though. And we reassessed after the second bolus and the child's signs had started to resolve. That means that her palms got a little warmer, her pulse rate came down, her capillary fill improved, as well as her mentation. Her GCS started to come from 11 to 12. It was getting a little bit more awake. At that time, we couldn't take her BP, but we looked at clinical signs and we saw some improvement. So we decided to now switch to giving the maintenance and fluids. So in this case, we had to calculate both her fluid deficit and maintenance fluids. So the maintenance fluids, we use the Holiday Sega formula, that's 150-20 for the first 10 kilograms, you give 100 mils per kg, you calculate rather, multiply. The next 10 you multiply by 50, and the remaining 22 kilograms in this case, you multiply by 20, giving us a total of 1,940 mils. Then we went ahead to calculate her fluid deficit. This is a child who was severely dehydrated. So we estimate that her fluid deficit is about 10%, which is a factor 10 minus her kilogram body weight. You would arrive at a total of 4,200 mils. So when you combine the maintenance and the fluid deficit, you come to a total of 6,140 mils, which we expect to correct over 48 hours. So when we calculated, that was about 120 mils per hour. Luckily now in the acute care unit, we have infusion pumps. So it's easy to give those fluids per hour at a titrated rate. Now she was in shock. So we did not subtract the boluses that we gave from this fluid. But if she was moderately or severely dehydrated but not in shock, we would have subtracted it from this total. So over 48 hours, we expected to give her 6,140 mils of fluid. Our target for glucose, we hoped that with all our interventions, we're looking at a target of between 5 and 12 millimoles. But obviously, as far as monitoring is concerned, I guess before I go there, I remember I asked if we were to start insulin immediately, immediately when we found the patient having an RBS as high. We did not start the insulin then. We started the insulin after correcting her shock state and giving her the bolus fluid. So that took us about an hour or so. So our target was if we started the insulin infusion at 0.1 international units per kg per hour. So she's 42 kilograms. So we set it at 4.2 international units per hour. And again, I said in our unit, we have infusion pumps, which might not be the same in other units. So our target was if the RBS was at any point to drop below 15 millimoles, we would switch the fluids from using normal saline to now switching it to using D5%, which actually happened because she had swings as low as 3 millimoles, 2.2 millimoles, while in the unit and even while on board. And at that particular moment, they switched from normal saline to using D5%. When the RBS dropped below 5.5 millimoles, what was done was to not only switch from D5, but go ahead and switch to D10 as well. And if for any chance that despite switching from D5 to D10, the RBS continued to drop, we would then have to half the amount of insulin we are giving, maybe go to 0.05 international units per kg per hour. But the point was never at any point to stop the insulin infusion. It was to continue, but just change the type of fluid that we are giving her. Fortunately, we did not meet a situation where her RBS kept to drop despite these interventions. So at the acute care unit, we got consultations and reviews from the pediatric.
Rebecca, kindly use the next 2 minutes to summarize so that we can give time for the expert for the next few things that we have to share. Our time is fast. Yeah. Thank you.
Yeah, thank you very much. So consultations were made and the child was transferred to the pediatric endocrine unit where glucose and electrolyte monitoring continued. The complications that we watched out for, like I told you, was hypoglycemia and also cerebral edema, which was encountered on the second day of admission while she was on ward. Her Glasgow Coma scale, which had improved up to 15 out of 15, by the time she was discharged from the unit, it dropped back down. She became aggressive, confused. So a high index of suspicion was made of cerebral edema, and interventions to reduce that were started, inclusive of administering mannitol therapy. And within 24 hours, she had improved. The patient was later discharged on insulin therapy, alive and well. Yeah. So I guess for time, I'll let the expert come in and give us his thoughts, as Dr. Anna said.
Yeah. Okay. Thank you so much, Dr. Rebecca. I think this was a very nice and a sweet case that we need to deliberate on. I don't know how much time we can agree or take a contribution from the House, but maybe a few things I want us to just recognize with this case is that, one, the solution for pollution is dilution. I don't know if that's a common analogy or a common statement that we all know, that the solution for pollution is dilution. So there were questions as whether you should have started insulin early or late, whether you should have given potassium early or late. Again, you realize that the biggest issue now here is hyperglycemia that you saw. And of course, maybe let's start by saying the triad of diabetes, like we said there. What's the triad? Someone from the House or anyone of you, the presenters? When we talk about the triad of diabetes, there are three things that we look at. DKA. What are they? Someone quickly. I can't see hands. Can I go ahead? Can I assume you've given it to mention it? Okay.
I think there are people in the chat.
Yes, Masa. Okay, I've seen some hands, I've seen some responses here, but of course, because of time, we're talking about hyperglycemia, which we saw in this patient, our girl of 15 years. We're talking about ketonemia, ketones. We should have actually been able to see this as well. And then, of course, what's very important is you cannot talk about DKA, which is a metabolic case, and then you fail to talk about a high anion gap metabolic acidosis. So those are very key things. But you realize that all these tend to start reversing as soon as you start correcting the shock, the hypovolemia, the shock that we saw. Ultimately, even if you delayed starting your insulin or starting your potassium because of diagnostic challenges, at least you shouldn't fail to start normal saline for your case, all right? Which I think you guys did so well there, right from the pre-hospital side up to the ED. And then, of course, to know again, are we dealing with the mother? From the history, the mother had a history of, she's diabetic and she's on treatment. Could this child have had diabetes as well? Is this a new case, or it is an old case that went missed doses of treatment? That's why history becomes very important. We may be dealing with the DKA, which is as a result of missed treatment or non-compliance, or alternatively, a newly diagnosed case. It's very, very important to mention that. And then, of course, watch out for other social determinants, ability to buy the drugs, for example, availability of the medications, storage of some of these medications. All those are social determinants that can affect the outcome of this case. I think that's what I wanted to sum up. But yes, looking at the HbA1c, it was raised. And I think as long as you find hemoglobin A1c raised, it is pointing towards a chronic case. So this is a patient who might have had diabetes for some time, but it was not diagnosed, at least more than 3 months. Maybe it was not diagnosed. Again, it goes to say maybe it was on the patient was treatment, but there was no sufficient information to inform us whether he missed a dose or completely new case. Talking about cerebral edema, we must know that cerebral edema, most of the time, there are so many theories. Some people tell that they don't know the reasons why cerebral edema occurs. But most importantly, most studies have pointed out to the rapidity, the timing of initiation of IV fluids, or how quickly, how aggressively you use the IV fluids. If you delay to treat hyperkalemia, hyperglycemia, if it persists longer, the patient risks going into cerebral edema. If you correct it again, if you correct the hypovolemia too fast, the patient runs into cerebral edema. So you have to balance this. Okay? And then some people have gone ahead to use bicarbonate. And we don't have any evidence to support the benefit of using sodium bicarbonate, especially in kids. So you try as much as possible not to use it. Just use your fluids, establish your sugar, and begin correcting it in a manner that is responsive. Don't be so aggressive, but taper it down gradually. I don't know that answers most of the issues that we raised. Feel free to interject so that I may point out to other issues that might be pertinent that I've not mentioned. But very importantly is do not delay with your IV fluids, and then be very deliberate with your information. And then don't forget the mother completely out of the picture. You realize that this is a child and probably is going to have a prolonged stay in the hospital. And again, there is a financial aspect towards this whole management, which the mother definitely or the family has to come in. So let's not forget to discuss our medicine and forget the family, because they feed into this. Does that sound okay? Dr.
Yes,
Anna?
it does. Thank you so much. Yes, it does. Thank you so much, Dr. Pius. We have 6 minutes to the end of this session. I'll open it. I'll give the next 2 minutes to the audience. If someone has a burning question to ask our experts today, I noticed George Amalo had his hand has been up. You can take this moment to unmute and ask your question. And then please don't log off. We're going to get an opportunity to go through the poll questions that were projected for us just to incorporate our knowledge together. George, please unmute and ask your question, or anyone else who has a question in the next 2 minutes. Thank you.
Okay, thank you, Anna, for great presentation also from Rebecca. So my question goes to the pre-hospital care team, because I was trying to understand the patient history and the etiology, but now again I was looking at how they manage to like, for example, manage the physiological changes, particularly with the clinical presentations of the patient. So some of the things that I was keen about the clinical presentations like cold extremities and vomiting. They didn't say how much, like they didn't like tell us how much was maybe the patient vomited before they reach at the scene, so that they can be able to know. Because when we have a patient who is vomiting, you are also looking
George,
at the. Sorry,
George,
hello.
what is the question exactly? Kindly just in one sentence tell us what the question is. Kindly without re-echoing the whole history, please.
Okay. I just wanted to know how they manage the vomiting, and also the issue of the cold extremities, and yeah.
Okay, thank you. Winnie, would you want to attempt to that in 0.5 minutes?
Yes. Thank you, George. So the patient vomited twice, and we can give that an estimation of around 200 mils of vomit when measured. So how we managed that, first, we noted that the patient had the cold extremities. So we tended to warm to attend the shock by warming the patient using blankets. And also we managed by on transit we give 500 mils of warmed normal saline to help with that. I hope that answers you. Thank you.
Thank you, Winnie. Dr. Daniel, in 1 minute, is there any question that is burning in the chat that you would love to attempt?
Thank you very much, Dr. Anne, and thank you very much to the presenters as well. It has been an interesting case. The chat has relatively been busy, and one of the contentious questions was someone wanted to understand when we stop CPR. So I would really love to take this further with her, but then the understanding would be that resuscitation was carried out. Resuscitation is really stabilizing the patient and trying to bring the deranged physiology back to norm. We are attempting to bring it back to norm. We may not achieve it in the shortest time possible, but this aids the primary care team. So that's like internal medicine, the endocrinologist, to get a living patient so that now they take them to that end where the body comes back to normal. And just as a take home to the team, DKA tends to present because of mainly one, first timers presenting to the ED, and two, missed treatment. So if you have not had your refill, it comes in. Then others like infection and stressors also follow up. Just to back up on what Dr. Pius had earlier mentioned about the risk factors for DKA. Thank you, Anne.
Okay, thank you, Dr. Olinga. It's 8 p.m. I'll use the next 2 minutes to kindly ask Emma. Can you project for us the first poll questions? And Dr. Rebecca, you'll use 1 minute to 1.5 minutes to go through those poll questions. Thank you.
I'll wait for the poll questions to be projected. One.
Okay, while that is being projected, I wanted to just re-emphasize that CPR is different from resuscitation. They look like one and together, but they're different. CPR is a completely different thing, but resuscitation is the whole continuum of care of the patient. Thank you. Go ahead with the poll questions.
Rebecca, the poll is open for you.
Right, so in the poll questions, what kind of shock did the child have? The answer is hypovolemic shock. hypovolemic shock in light of the history and clinical presentation that the child has. She has evidence of loss through vomiting and increased polyuria and decreased intake. And she also presented with signs of shock in addition to that. The next question was, okay. Maybe if you can please project the next question. How much fluid do we administer in a child with shock? We had 10 mils per kg, 20 mils per kg, 30 mils per kg, and 1 liter start. And it looks like most people picked 20 mils per kg, which is the correct answer if we are managing a child with shock. The next poll question. How soon do we start the insulin infusion in this case? Do we start it immediately after the first fluid bolus, after an hour, or never? So most people look like they answered it as immediately, which is wrong. We are supposed to start the insulin infusion at least after an hour or two of giving fluids. Especially if your child is in shock, you have to first correct the shock state. So you start the insulin infusion 1 to 2 hours after starting your fluids. When you're managing DKA, primarily you want to start fluids before insulin. That's according to the latest guidelines, inclusive of ISPAD, our Ministry of Health guidelines here, and the British Society of Pediatric Endocrinology. So we can go to the next poll question. So the answer here was after an hour.
Those were the only projected questions. We will not go through the rest. So thank you, Dr. Rebecca. Thank you, Winnie. Thank you to our expert, Dr. Pius. It was great having you around. Thank you to Daniel for managing the chat. Thank you, everyone who worked behind the scenes. Projected is the wall of fame of the team that works behind the scene that you never get to see or hear talk on this forum. Thank you, everyone, for joining in and for listening and for staying till this minute. Just a reminder, these sessions happen every month. We welcome cases. If you see an interesting case, please don't keep quiet with it. Send us a chat. You could, if you're in Mbara, you could reach out to Dr. Daniel. If you're in Makere, you could reach out to Jimmy. If you are wherever you are, there is always at least someone to reach out to. Share that case with us. We can get you a mentor, or you can get yourself a mentor in your session, in your area of study, and let us learn together. If there is anything more to ask at this point, I'd like to bring this session to a close. Thank you once again for joining in.
Yes, Dr. Ann, thank you so much. I wanted us to recognize someone, the EMT from the presenter, Winfred. I think that's Masinde Muliro University. Is that in Uganda?
No, it's in Kenya.
It's important to recognize the contribution that we are getting from our neighboring countries, because this is a worldwide learning forum. Thank you so much. That's all I wanted to recognize. Thank you.